Welcome, everyone. I'm Kelly Grant, Vice President of Business Development, Admissions, and Case Management at Caron Treatment Centers. Welcome to the first installment in Caron's signature program virtual open house series, with today's session focusing on the Grandview Women's Program. Caron's signature program addresses the unique clinical, medical, and psychological needs of certain populations that require a specialized concierge level of care for substance use disorder and mental health conditions. At the core of these programs is our highly credentialed team who provides evidence-based, fully customized care that elevates patients and their families to achieve the best possible outcomes in recovery. Signature programs also feature secluded deluxe accommodations, as well as ancillary services that contribute to a safe and comfortable treatment experience. The latest addition to our catalog of signature programs is our Grandview Women's Program, which has been designed to empower women in a comfortable and emotionally safe place to rediscover their purpose and put fulfillment back into their lives. Today, we'll meet some of the expert staff who work with the Grandview Women's patients, but first, we want to take you inside the unit virtually to get a firsthand look at our facilities and the philosophy behind this innovative program.
My name is Dr. Wang. I'm the medical director of our Grandview Women's Program on this campus. When patients first come to us, the foremost task that we must accomplish is make sure that everyone is medically safe from a withdrawal standpoint, from a detox standpoint. We have the largest medical and nursing department of all treatment facilities in this country. Me and my colleagues, we are all addiction medicine boarded, as well as boarded in another specialties. We are experts in addressing addiction issues as well as other medical issues while our patients are here with us. Here at Caron Treatment Centers, we take care of our patients with a team approach. The team consists of the primary counselor, the physician, nursing, the psychologist, and other support staffs that may be helpful in a patient's care. We take this approach because we address many co-occurring issues here at Caron Treatment Centers, not just medical, not just mental health or addiction issues. In order for us to be successful in treating our patients for their substance use disorder, we must take a global approach to all problems that potentially could derail their recovery.
My name is Erin Goodhart. I'm the Senior Clinical Director of Women's Services and our Family Program. I've been at Caron since 2004 and have worked primarily with women during my time. I'm also part of the trauma team and trained in EMDR and cognitive processing therapy. Grandview Women is a home-like environment. Each of our patients have their own bedroom with a TV. They all also have their own personal bathrooms. We have a massage therapy room where our patients can receive both medical massage and recreational massage. Our patient lounge provides an area for the women to connect with each other, watch movies together, play games, complete art assignments, and just have a genuine opportunity to connect with other women in early recovery. Our patients receive a high level of individualized care by master's level therapists and psychology staff. Gender separate and specific treatment allows for vulnerability with each other and to practice open and honest communication with other women. In Grandview Women, we recognize that many of our patients present with a complex number of concerns and areas of growth. One of the things that we found to be very helpful is the use of neurofeedback, especially as we consider women who have trauma histories. All of our patients receive a brain map when they come into treatment. Our staff is trained in addiction interaction disorder, so we're able to look at things like compulsive shopping, sex and relationships, over-exercising, and even some concerns around overworking. One of the things Grandview Women offers is the privacy necessary to participate in work activities as needed. Each of our patients receives a family therapist who work exclusively with their family to provide both family therapy sessions and family updates. Recovery for life is our primary goal at Caron, not just for our patients that come through our front doors, but their families and loved ones that are also impacted by substance use.
I'm Jacqueline Guthridge. I'm the clinical supervisor for the Grandview Women's Unit. I've been at Caron for almost 10 years. I've worked with women for 9 of those 10 years on primary treatment, relapse treatment, extended care, and now at the Grandview Unit. I'm a certified sex addiction counselor, multiple addiction counselor. I'm also a part of the trauma team and do cognitive processing therapy. So as a patient coming onto the Caron campus, we have a nutritionist who will meet with the patient if the patient has a history of an eating disorder, gastric bypass, any allergy, because it's important for us to know, how to best serve the patient. Since Grandview Women have opened in September, we've been able to treat women from the age of 27 to 75. We have patients who have been in treatment and have had recovery before, and we have patients that this is their first time in treatment. So they have that ability to interact together and to lose that sense of hopelessness that they came in with, feeling that how can I manage all of this, and then go back home to to run my company or to take care of my family. It creates change that I don't think anything else that I've seen does.
Now, I am pleased to introduce our Grandview Women's team, a team of people that I have had both the privilege and the honor to work with for many years now. Cheryl Nepper is joining us as the Senior Vice President of Clinical Operations at Caron. In the same room with Cheryl, we have Erin Goodhart, Senior Clinical Director of Women's Services and Supervisor of Family Services. And we have Jackie Guthridge, Clinical Supervisor of the Grandview Women's Program. For social distancing purposes, are joined in another room by Dr. Ming Wang, who is the full-time physician with Caron and provides medical supervision of the Grandview Women's Program. And joining Dr. Wang is Dr. Ramona Roberts, who's the clinical supervisor of trauma services and provides psychological support for the program. We also have Megan Schlott joining us today, who is the director of admissions for Caron Treatment Centers. We will start with Cheryl Nepper, who will reiterate and add to the general overview of the program provided in the video we just saw.
Thank you. Thank you for joining us. Thank you, Kelly, for that wonderful introduction. And thank you for participating in this program this afternoon. I am very delighted to be part of Caron and to be part of this team that is comprised of women and men who treat this population. 6 years ago, we developed our Grandview Services, which was a high-end signature program for executives. During the course of those 6 years, we realized that we had an increasing number to that program, so it became co-ed. Over the last couple of years, we saw an increase in women needing their own separate unit for signature services in a concierge manner. We have a small private unit here of 11 beds. A lot of amenities, as you saw in the video, and a team that does a lot of individualized care to our patients. Our reason for developing this particular program is because the women we saw coming to Grandview had a lot of trauma situations in their lives that were either developmental or through the course of their addiction became uncovered. As a result of that, we needed a safe environment to continue to process those issues. So surrounding this particular team are those who are well credentialed in treating trauma and other addictions, as well as our signature medical staff. We need this program. Women do well when they're amongst other women. We know that. Women in recovery can be dynamic and diverse and can also give back. A key component of this program is the integration of our alumni. Women who've come through this program just recently, or women who have been through our other women's services or other programs here on our campus who give back. This particular program is here today because of one woman who has given back generously to Caron to help us build this program, Carol E. Ware. So I want to give credit to her. We're here today in this beautiful building because of the journey that she's had and the recovery that she's had with many of this team surrounding us here today. Again, thank you for being with us. We're very excited to share with you more about our clinical services in detail with the wonderful team that surrounds me. Back to you, Kelly.
Thanks, Cheryl. Thank you so much for that. Next, we're going to hear from Dr. Ming Wang, who you saw in our video. And Dr. Wang will speak a little further about our medical acuity and the detox process.
Hello, everyone. Welcome to this conference. And our medical and nursing department has been in existence from the very beginning at Caring Treatment Centers. Over the years, we have expanded our medical department as well as nursing department, as well as refine what we do here. Since Dr. Garbley took over as our Chief Medical Officer, we have expanded dramatically. Not only are we skilled in managing withdrawal of all substances involved here, but we also are one of the very few treatment facilities in this country, privately owned, that has an ACGME approved addiction medicine fellowship program. So not only are we a very large facility, medical nursing, but we are also a very academic institution, training the next generation of addiction medicine specialists. And all patients who come to us, the foremost thought that we have is make sure they are medically stable from a withdrawal standpoint. And oftentimes our patients come to us lacking self-care during their substance use. And so we make sure that they are medically stable from a primary medical standpoint as well as withdrawal standpoint. We also collaborate with our sort of a sister institution, Reading Hospital, down the road here, for anyone who might require a higher level of care, acute care, such as those people who might have severe diseases, maybe secondary to their substance use, such as liver cirrhosis. And so our program here, from a medical and nursing standpoint, continues to be expanded and refined. And we are confident in what we can do here and accomplish.
Thank you so much, Dr. Wang. Now we'll move on to Erin Goodhart and Jackie Guthridge, who were also featured in our video. They'll give us a deeper look at the typical profile of a Grandview women's patient, explain the treatment modalities we use, and discuss how we work with families.
Hi, everyone. Thank you for coming. Who do we treat here in Grandview Women? This is one of my favorite questions because it is such a broad answer. We treat women of affluence, women who are CEOs, women who run their own companies, lawyers, women who don't work at all, women who are home taking care of their families. And the age range has been, so far since we've opened, 27 to 75 years old. Erin, I don't know if you want to add to that?
No, I mean, the other thing I would say is that women who have multiple treatment experiences, women who have sort of they want a real tailored, and I know that is something that a lot of places, say tailored, highly individualized, but these are truly women who are getting assessed by top-notch and really getting a very individualized treatment experience, not only for the patient, but for their family. So one of the things that is very unique to Grandview Women's Services is all of our patients get connected with a family therapist within the first several days of treatment. Our family therapist is reaching out to family members, not only to provide information about substance use, behavioral health, but also really about how this journey has impacted them as well. So providing them both with therapy support, family therapy sessions, and then one of the things that we've, as we all have had to pivot with COVID, is making our family education program virtual. So all of our families are invited to an educational experience, much like this, that's interactive with our family therapists.
and really engaging with the family throughout the entire treatment experience.
I want to talk a little bit about the treatment modalities, as you mentioned, Kelly. Here we are very fond of doing DBT with our patients, and we've had great responses from not only patients, but family members as the patients start to use DBT with their families. CBT is something else that we offer patients individually and in weekly groups, helping the women to look at those core beliefs that impact how they interact in all of their relationships. As far as trauma goes, and I'll let Dr. Roberts elaborate on this, but we do cognitive processing therapy, EMDR, with our patients, and we'll be adding expressive art therapy, and I'll let Dr. Roberts expand on that.
The only other thing I would add, and this kind of ties in with patient profile and treatment modalities, is with a lot of our ladies, we're really starting out with a lot of motivational interviewing. They're often coming in here uncertain if they even have a substance use disorder, a behavioral health concern, often with pressure from family, employer, or children. So we're also really kind of starting with that motivational interviewing piece, moving into some ACT therapy, some that real solution focused, looking at that thinking process. So again, just a really eclectic approach that we can take. We do group therapy every morning, which is really like a Gestalt therapy session where we're, where do we need to go today? Let's talk about what's happening in the room. And that's been really rewarding to see women become assertive and have healthy communication. I think it's something that we're not always taught how to do, and we do need to learn to do those things.
And if I can add one other thing to that, this may keep going. We do once monthly an experiential 2-day program with the breakthrough staff leading it. So that's another expressive therapy that the women really benefit from in being able to kind of launch forward a little bit more quickly and from those areas of family of origin that they've been stuck on for quite some time.
Thanks, Jackie, and thanks, Erin. Next, we have Dr. Ramona Roberts, who will share more about the psychological services we provide.
Good afternoon, everyone. So for our patients, every single one of them gets a full diagnostic psychological evaluation that also comes with some basic screening measures that can indicate a need for additional psychological testing. If indicated, we have another single layer, single battery that we can utilize and employ to really help us illuminate any additional characterological or mental health presentations that may not be so obvious at the start. If the diagnostic question then becomes even more unanswered, we have another layer of psychological test batteries that we can offer at an additional cost. But the psychological evaluation and those screening measures or that single battery are really helpful in the overall conceptualization of their presentation and can inform our treatment planning, the treatment goals, the interventions. So we, as you saw on the video clip, Dr. Wang did mention the co-occurring existence here of multiple conditions. And so if you look around in the literature, you'll see that about half of patients who have a substance use diagnosis also carry a co-occurring mental health disorder as well. That number can increase depending on how we hone in and filter out that research question. And we also know from the data that only about 10% of those individuals actually get simultaneous treatment for both conditions. So here we definitely are informed by evidence-based treatments and interventions, and we do believe in treating simultaneously their substance use diagnoses along with their mental health presentation. So we do see that mental health and substance use are connected in a number of ways. We see a lot of self-medicating, a lot of coping mechanisms that include substance use, and whether that's depression, anxiety, or to help them with trauma symptoms. So those are some of the common co-occurring presentations we see. We see a number of mood disorders, trauma, and other stressor-related diagnoses, including PTSD, a number of anxiety diagnoses, and we address them from a number of areas. As Jackie mentioned, we have CBT that we'll utilize individually and in group form. And there are some exclusionary criteria if someone is in, let's say, active mania, or there are acute safety concerns at the time of admission. Sometimes, also if we have acute or active eating disorders, some of these things may not be very evident at the time of admission. So if they arise in treatment, as Dr. Wang also mentioned, we will utilize Tower Health, Reading Hospital Services, or refer out to other more appropriate levels of care if needed. We have, as Jackie mentioned, a very nice trauma programming here. I'm really proud. I may be biased as trauma supervisor, but I'm really proud of our trauma team, especially over the last couple of years in the specialized treatments that we've been able to get trained in. We have a number of clinicians that are combined trained in evidence-based treatments that include, as already mentioned, cognitive processing therapy and the eye movement desensitization reprocessing. We've also had a number of clinicians go through an expressive arts training that's trauma informed. So we will be incorporating that into our what we call phase 1 trauma programming soon as well. So our trauma programming is set up on a phase-based system that is informed by the research that's out there, both nationally and internationally, in focusing on safety and stabilization first at the core. So our phase 1 trauma programming includes trauma-sensitive yoga. As some of you out there know how much trauma is stored in the body, right? And we can listen to a lot of experts in the field in that area, and we need to address the physical experience. Also in the phase 1, we have psychoeducational groups that focus on building curiosity, that focus on creating and providing a language to the patient's experience, helping them understand how trauma impacts them in a number of domains, including how trauma impacts the brain, safety, relationships, just to name a few. And then again, we'll be incorporating the expressive arts as well in the phase 1 programming. Our phase 2, so phase 1 focuses on that safety and stabilization component, and phase 2 is a much more individually focused treatment intervention where the patient will work individually with either a master's level or a doctoral level clinician that has been trained in, again, either EMDR or CPT. And they will also be able to still attend the phase 1 components as they're going through that process. For the CPT and EMDR, both evidence-based, CPT is a 12-session protocol. And here we utilize it in the form of 2 sessions per week. So we're looking at a 6-week treatment from the start of their first session. So they may come into treatment and not start CPT until, let's say, several days later or a week in, potentially 2 weeks in, depending on their stabilization. And then we take 6 weeks from there to allow for the 12 sessions. And what we focus on in CPT is challenging those unhelpful belief systems, what we would call stuck points in CPT. And it really helps to alleviate a lot of those intrusion symptoms, the experiences of guilt and shame, and it cuts down on their coping mechanism of avoidance. We have seen a number of patients go through CPT that have met criteria for a PTSD diagnosis at the start, and by the time of discharge have no longer met criteria for that diagnosis. It's pretty exciting to see patients be able to attain that. For EMDR, we focus there on dual attention bilateral stimulation. Sounds very technical. It's going to involve eye movements with the clinician's fingers and tapping as well. And with that, we really help to reduce the impact of memories and the emotions associated with them. It's an approach that addresses the physiological storage of memory and how it informs experience. So with EMDR, it's less structured like the CPT and the 12-session protocol, where EMDR, we may start them with a few to several sessions while they're here with us. For some patients, that may be all they need, and for other patients, they may need to continue on with an EMDR clinician post-discharge, and we will set them up in that process. We have EMDR clinicians that we will refer them on to continue that healing process. So we also, as Erin talked a little bit about the family component, we did add in after really seeing the need. It's neat how Cheryl explained how this program even came about. Is we learn from our patients, and we see the needs that are there, and we want to come in and address them. And so one of those for us in trauma is needing to educate the family. So in addition to their regular family experience in treatment, they have an opportunity to participate in what's called the Trauma Family Webinar. So those family members that are identified by the patients are able to really themselves start to build a language for their loved one's experience as well, and make sense of it and understand what the behaviors and the actions of my loved one mean and why they're coming about and what's happening in front of me. So that's been an exciting addition as well. So I think that sums it up for me.
Thanks so much, Dr. Roberts. Now we're actually going to return to Erin and Jackie, who will provide a snapshot of what happens with a Grandview Women's patient once they're discharged from our care.
Thank you, Kelly. So there's a number of ways that we follow up with our patients after discharge. Some of them are formal processes and some are sort of more informal. So I'll start with more of the formal ones. We have a program called My First Year of Recovery, which was developed and really modeled after the program for healthcare professionals, where we follow patients for 1 year. Within the last couple of years, able to use breathalyzer. So we're getting real-time information. We're still sending folks out for urine drug screens. And actually, they just started doing swabs. They can just swab at home, send it in, and we get those results pretty quickly. It also involved is not just the kind of physical, biometric pieces, but there's also a weekly check-in with a case specialist here, one of our therapists on the My First Year team. And they're asking things like, obviously around abstinence, but also around the management of co-occurring disorders. Are you maintaining your therapy? If you're using a 12-step program, do you have a sponsor? Are you going to meetings? If you're using Refuge or Celebrate or any Smart Recovery, any other number of recovery systems, what are you doing to support your recovery? And then also along with that, we're checking in with the family members as well every month from their perspective to say, how are things going? We've seen a lot of success with that program, and it's really been, the My First Year staff will send us updates, 10 months, 1 year. And even if people relapse during that time, the re-engagement is so quick because we catch it really quickly. So that's a kind of and we've actually found a lot of our women, I would say, are enrolling in that program, and it's really providing another level of support for them. We also, out of New York and Plymouth Meeting, and Atlanta, we have in-house services also that look much like My First Year. But again, it might be that they're, the case manager is going to a meeting with them or coming into their home with them, helping them to kind of like organize things. And then they're rolling into the My First Year Recovery program. We have our alumni staff who reach out at certain intervals throughout the process. So 1 week out, 3 months out, 6 months out, and 12 months out, so that we can kind of keep them engaged. And again, if they're struggling, pick that up really quickly. We've had some women who have come back in for kind of re-energizers, either before they've relapsed or after they've relapsed. And we're really working hard to engage them sort of proactively, to have them come back, like Jackie talked about, the breakthrough intensives, have them come back for an intensive that just kind of recharges them. And then we also, like to stay in touch with the referent and the therapist who either referred their patient in or that we referred to after treatment. And I'm going to let Jackie talk a little bit about the way she stays connected, because again, I think it's one of those things that really, You know, our staff on this unit is so small and the patients get to know all of us that I think what Jackie's doing really sets apart from other programs in terms of just that connection piece.
Thanks, Erin. So one of the things that I do is I connect with alumni usually 2 to 3 weeks after they've left treatment. I wait that long because our alumni staff is checking with them prior to that. I stay connected with them whether they're struggling or whether they're not. If they're struggling, we meet together as a team and talk about how we can be supportive to them. We've had several patients come back into treatment as a result of these connections, of them feeling comfortable to come back with Karen. I think every one of us have reached out to alumni for one reason or another, so it kind of feels like a big family, and which is getting larger. One of the other ways that patients stay connected is through the regional alumni support groups, and they are located in, let's see if I can get all of these, the Lehigh, Lancaster, Berks County areas in Morristown, New Jersey, Philadelphia, DC, New York. I think I hit them all. So these are alumni programs that are run by our alumni staff. But the alumni are empowered to take over those groups and make them their own. And they have done an amazing job with that. We're actually starting this week to Zoom in to alumni meetings from treatment so that the patients can get an idea of what that feels like and start extending into their extended family, if you will. One other way that the patients stay connected is through what we call 12-step contacts. So Erin touched on the alumni part of our program. The alumni part is so huge for us because when women come into treatment and feel like there's no way that I'm going to be able to do this, to stay sober and then to return home, the women connect with alumni twice a week here in this room. So it's interactive, one alumni and the patients really get a lot of hope from that, and they stay connected to those alumni. And the patients also get a 12-step contact. So that's another woman who has typically been through Karen, who our alumni staff keep in contact with so that we know that they are working a program of recovery. And these are women that our patients can connect with and have an extra layer of support. I think that's it.
Thanks, ladies. Finally, we will hear from Megan Schlott, who will share more about admitting a patient to the Grandview Women's Program.
Thanks, Kelly. Hello, everyone. Our admissions team is here 7 days a week to support patients, families, treatment providers at any point in their treatment seeking journey, whether they need to get into treatment in an hour, they need treatment in 2 weeks, 3 months from now. We will work with the family to the fullest to evaluate what the best recommendation is here at Karen with our Women's Grandview program by assessing and evaluating all of the things that our treatment professionals have mentioned so far: their medical history, their substance use history, their mental health history, gathering all of that information ahead of time to prepare their entry here. So it feels like a seamless transition from their home, from another level of care, wherever they are in their process of getting here. And that oftentimes means connecting our patients and families and treatment providers to our clinical team here so that they can hear from the professionals that they're going to be working with. They know the faces, they know the names by the time they step foot in our door. We work closely with our medical team on their detox needs prior to arrival, so we're prepared and ready once they are here on our campus to make sure that their treatment is the safest as possible, and connecting their family so that they're updated, very clear understanding, transparent understanding of what the length of stay is going to be, what the financial expectations are, and how we'll be able to work with them on an individual basis when they get to our campus.
Thank you, Megan, for that. And now I'll just briefly touch base on our case management department, which is my baby and what makes my heart beat fast. So I'm a little biased to it, but we have a team of folks who work very collaboratively with our clinical team, our medical team, and our admissions team So for referrants, patients or their families who have a referral into Grandview or any of our programs, that we can truly hold their hand, make this process as easy and as seamless as possible, and ensure that Caron is the best placement for them. We are very fortunate that we work with a lot of good providers all across the country, so we want to make sure we always do right by our patients and their families. So if Caron is not the best fit for whatever reason, we make sure we get them there. And if Caron is the best fit, then we make sure that we make that process as seamless as possible. Now we're going to move into answering questions that we received through the registration and the live Q&A. If you haven't done so already, please submit your questions using the Q&A button that's located at the bottom right of your screen. We've already gotten a lot of questions submitted, so if we don't have time to get through all of them today, please know that someone from our team will be following up with you to make sure that your question has been answered. So the first question we have is, what are some of the biggest challenges with treating substance use disorders among executives or patients coming from a more affluent background? So who would like to take this one?
I can start with that one, and I'm sure others will join in. So one of the biggest fears that patient executives have coming into treatment is, how do I still stay connected to my company, my business? And we provide that opportunity by talking with them typically before they come into treatment and kind of laying out what the time opportunities are and to hear their specific needs. Secondly, I would say is that the fear of, how do I return back to my job and stay sober? Because it seems nearly impossible with the entertaining that the executives typically do. And I will say that reaching that connection with our alumni right there offers them the hope that they can get through this and be able to live a happy life. Erin, did you have others you wanted to touch on?
Yeah, I mean, I think the other thing that with our executives and even our folks who come from more affluent backgrounds, there's a level of privacy that they also prefer. And so I think that's one of the things that's made both the Grandview Women and Grandview Men's programs very special, is that we are a very small unit. The other folks on the unit tend to kind of understand that desire for privacy. The clinical team certainly understand that. And then the other thing that's been interesting, and I mentioned this a little earlier, is that it's often, work is one of the things that's also motivating them into treatment, because they're able to kind of hold it together there. And so, working on things like, how do you balance, you have group therapy and a board meeting? How do we help you to navigate those things? Because in real life, you're going to have a therapy or a meeting, and you're going to have a board meeting. So how do we help kind of navigate those things? Our patients do have access to their electronics. So they'll have a cell phone or a laptop as needed. But again, I've seen Jackie and the clinical team really get creative around, right before group is not the best time to talk to your partner, because they get you revved up and then your group is all about your partner who's not even here. So we've been able to get creative with things like that. But I also think just kind of looking it squarely in the face and not trying to avoid it has been very helpful.
I think there are also a group of folks that are very intellectually gifted and want a lot of educational information. So we spend a lot of time balancing that therapy and inside work along with the educational pieces. So spending time with our teams, educating them about why would we recommend a brain map and neurofeedback services. They're usually very inquisitive about the services that we provide. And also, just to add the family pieces to these folks that are executives. Many executives do a lot of work away from home. Their hours are very long. Their family are waiting for them. So the work that we do with those families is really intensive, getting in there and helping them find the balance between their own life at home, the work, and the energy that comes home with them. So I think a lot of what you said, Erin and Jackie, really falls in line with this particular population.
We've also had many women who came into this program because they could stay in connection with their family, with their young children. And so we've done a lot of work around helping them to find balance, because we find early in treatment that these women are still trying to be at home. And by that I mean ordering groceries, sewing costumes for their children, because they're too fearful of letting someone else kind of step in for them. And they've done a tremendous job, all of the patients that we have, learning how to balance that way. Yeah, very key.
Thanks, ladies. This next question is really a three-part question, but they asked, I am familiar with the Grandview Men's Services and I've sent several executives to that program. What do you offer to executive level females in this program? And how are the needs of executive women different from executive men? And the final part is, how much time each day will a patient be allowed to dedicate to work? And what if work is part of their addiction?
I'll start with the needs of the executive women. So I think the thing that's very different is women working in a man's world, and we do spend a lot of time focusing on their special needs in that area. As far as their other needs, they very much match those of executive men. We do individual work with them and group work with them, specifically around professional concerns, or integrating back into, like I said before, integrating back into their professional life.
I also would say that, one of the things that's been, as Cheryl mentioned, when we had the Grandview Men's program, there had to have been 24 women treated up there during that time. And so between the Grandview Men, the Grandview Women's clinical teams, if we have one executive woman on Grandview Women, there might be times where she goes up and does a group with Grandview Men, because that's also like there's a comfort level there, right? But at the same time, doing some individual kind of coaching with the female. We have Eric Weber, who does a lot of executive coaching and really helps people reintegrate back into the workplace. And it's interesting on the women's unit, how we see this show up is they almost become like the organizer of everything. So like Saturday night fun night, they're like, okay, what game are we playing? Who's gonna organize it? What are we ordering? And so you can see like this business side kind of click in. And I always want to be careful that we still like embrace that and encourage that and like really empower women to continue to do that. I think that it's interesting when you have an executive woman on treatment and kind of how people respond to that, but helping them to continue to grow and really empower themselves has been a really unique opportunity.
And I think helping them continue to grow, because sometimes what we've experienced so far is if you've been a professional who's been a CEO of a company, you're used to controlling a lot of things. And so when you come into treatment, you're surrendering some of that control. So what we find very early on with an executive is that need to control everything. And so each day as a team, taking a look at how can we help them chip away and allow them just to sit in their discomfort, because they want to fight against that. They want to fight against it through saying, I'm only going to stay a shorter period of time, and negotiate that. So helping them not only address the executive coaching pieces, but let's also talk about how you have to clinically address those pieces that come along with being an executive, and allowing yourself to humbly just be part of a program where you can start to explore yourself, those pieces that may have gotten lost.
I think also the vulnerability piece. I've heard so many patients say vulnerability is equivalent to weakness. And that is definitely an area of focus and growth for them. And many of them have been told that.
Thanks, ladies. Dr. Roberts, this next question is for you. One of our attendees would like to know, collaborate on licenses and EMDR, are the two modalities used together? And also, is any of the trauma work ever done in a group setting, or is it always one-on-one?
So the difference between what would prompt us using a CPT intervention versus EMDR is in their symptom presentation. So CPT is really for a diagnosis of PTSD, and we are often looking at either single incident trauma there, or someone could have a more complex trauma history, but they have what we call an index event. And let's say someone has 5 experiences of trauma, but the third one is the one that stands out the most. It causes them the most intrusive symptoms. It causes them the most distress when thought of or brought up, and it's the one they try to avoid the most. When that index event is present, or much easier to be able to read the situation is that they only have one incident of trauma, then we know that the intervention of CPT is appropriate for them. EMDR is utilized for a number of mental health presentations and even outside of a mental health diagnosis if you look at the literature in the field. But the way we utilize EMDR here is for those trauma histories that are a lot more complex and developmental. So multiple trauma experiences, early childhood experiences. And so a lot of those individuals would have a diagnosis of other or unspecified trauma and stressor related disorders. And so that's how we would differentiate who gets which treatment. We try to make sure I want to say we are very key on making sure we are symptom driven rather than event driven. So we definitely look at their symptom presentation, the symptoms they're endorsing, to help drive which modality they get. The trauma treatments at the level of CPT or EMDR at this point are individually done. They are not done in a group format. We know that that there are some basic foundational pieces of EMDR that have been utilized in group formats elsewhere, and CPT is able to be utilized in a group format. But we don't engage that at this level because we find that that our individuals who are in trauma programming, they need that safety and stabilization piece. The majority aren't going on for CPT and EMDR, but they need that safety and stabilization piece. So that's where we utilize the psychoeducation in group format. And then those individuals that, again, based on their symptom endorsement, that are indicated for CPT or EMDR, will go off and get those individually.
Thanks, Dr. Roberts. And can you actually elaborate? We have another question that wants to know how we screen for complex traumas. And then once you do that, Cheryl, if you could elaborate on how we screen for addiction interaction disorders process.
So in screening, I want to make sure we put it out there that we aren't asking people to talk about all of their trauma histories, because that oftentimes is not helpful, especially at the start of treatment. So when they're doing their psychological evaluation with myself as the unit psychologist or another one of our psychologists, they are giving us some basic kind of what we would call in the field like headline versions of trauma. So we understand that they have a trauma history. We try to get a sense of what kind of trauma, interpersonal violence, sexual assault, in terms of types of trauma. But we are very careful about having their narratives, brought up in that initial evaluation. And we also know that treatment does not need to be focused on all of the retelling of their trauma for healing to occur. We definitely need them to be stabilized and regulated first before we can dive into any more intensive work like that. But we have, in terms of screening for symptoms and the criteria for the diagnoses, that symptom presentation, we use things like the PCL-5 is one that we really utilize to help us assess for the need for CPT. We have the trauma symptom inventory that we utilize. We have a dissociative scale that we engage if needed. So we do have some of those basic screening measures that, again, help with that clinical interview in really determining if the trauma treatment is needed.
Thank you. Cheryl, can you elaborate on the addiction interaction disorder screening that we do?
Yes. Each patient, when they enter Karen, does a psychosocial assessment with their clinical specialist and any of the other specialists on the team. But the addiction interaction disorder pieces that we screen in or screen out are based on whether or not there's a sexual addiction or a sexual history that might lead to an addictive process in nature. So love and sex addiction. I may also want to tell you a caveat about our clinical staff is that we have about 20 professionals here on this Pennsylvania campus that are certified as sex addiction therapists and certified as multiple addiction therapists through Pat Carnes, Stephanie Carnes, and ITAP. And so we utilize that initial assessment to screen. And then if someone does have a sexual addiction or a love addiction, what we will do is help educate them around those issues that are arising for them, sometimes not known initially at assessment, but might come to fruition during the course of treatment. So we will do a psychoeducational group, meet with those individuals, and also we do have gender separate groups for addiction interaction. We also know that there's other process behavioral addictions that might occur as well. So gambling is one of those, gaming is one of those. We do have several certified gambling addiction specialists here on this campus. We have also assessed them using the SOGs so that we're able to look at and screen through the South Oaks gambling screen whether or not that is compulsive behavior that's going to come to fruition and may lead them back to their substance use disorder. We also know that eating is another area that can become very addictive. And I'm talking about beyond the eating disorders, which we do screen for. I'm talking more about eating attitudes. So we do the EAT-20, which is an assessment that allows us to understand the person's eating aptitude and attitude. Many of what we see is food addiction. Oftentimes we'll see it rise up during the course of treatment, where you'll see people gain weight while they're here in treatment. Because they just feed themselves. Many of the process addictions that I'm speaking to you about are things that might come up during the course of treatment if the person has not self-identified early on in treatment. Many will also self-identify early in treatment that they may have had treatment for several of these other behavioral disorders. So we're going to continue to work with them. We're going to incorporate that in their treatment plan. We're going to incorporate that in their treatment day schedule. And we're going to incorporate that, for example, on continuing care. If someone has come in here and they need to be seeing someone individually for substance use disorder and sex addiction, we're going to find that best fit. And that is the way we look at all of those process addictions. We've got plenty that do shopping, we have plenty that do gaming. We try to stay current with the trends and any certifications that our professional team can have in their arsenal to help treat these coexisting other addictions.
Thank you so much, Cheryl. It looks like we have time for one more question. And Dr. Wang, I'm going to send this question your way, so if you can come off mute. An attendee would like to know more about the chronic pain services that we provide for our Grandview Women's patients.
Co-occurring issues definitely is something of concern to us because any co-occurring issues, including chronic pain, potentially could present as a roadblock to a patient's sustainable recovery. By co-occurring issues, what I mean by that is things such as mental health issues, medical issues, past trauma unresolved, and chronic pain. Many of our patients come to us initially exposed to opioids for a pain condition, which over a long period of time develops into opioid use disorder. And unless we address the chronic pain issues, we may leave that patient very vulnerable to a relapse back to opioid use. So we do have a chronic pain program here that includes not only the chronic pain group, but also various services that we use to manage the chronic pain condition. We have the expertise at care and treatment centers to provide chronic pain management because we have specialists who are very familiar with opioids and chronic pain conditions. So we understand, we have good understanding of what chronic pain is about. We're not talking about acute pain, but rather than chronic pain. One of the first thing that must happen typically in one with chronic pain conditions, we got to get them off of their opioids, which for some people, they have been on it for decades, continuously. And understanding the physiologic basis behind chronic pain and worsening of a chronic pain condition is a must. And we have a good understanding of that. So to get them off of their opioids and to provide other safe pharmacologic intervention and non-pharmacologic modalities of pain management is what we do here. So we do provide patients who are appropriate for these services, such as physical therapy, medical massage, acupuncture. We have a dedicated physician here who does our medical acupuncture. We also have other modalities that we find very helpful in providing pain control that's sustainable. Opioids are not sustainable management style for pain. We have been using biowave stimulation units, and also neurofeedback is very helpful as well for some chronic pain conditions. So in other words, when we take people off of opioids because of chronic pain conditions, we must find a sufficient substitute moving forward for them, and that's what we do here.
Thank you so much, Dr. Wang. And thank you to everyone from our Grandview Women's team for joining us today, and to all of our attendees, thank you as well. Before we conclude today, we'd like to share some opportunities from Caron Treatment Centers. We are hosting our next signature program open house on Tuesday, May the 20th. We will be featuring Caron's older adult program, and registrations available online by visiting the link on your screen. Additionally, we will be hosting a continuing education event next Tuesday, April 20th, called Value-Based Agreements, Revolutionizing Addiction Treatment and Improving Outcomes. And during this webinar, we're really excited to have our Chief Medical Officer, Dr. Joseph Garbely, as well as our Chief Executive Officer-elect, it's a mouthful, Brad Sorty, who will share recently published data and findings about how value-based agreements can lead to positive outcomes for patients, providers, and payers. And you can register by visiting caron.org/webinars. And please reach out to your local regional resource directors regarding admissions to any of our programs, questions on our services or resources or events in your area. And thank you all so much for joining us today, and we hope to see you again soon. Take care.